Okay, can you hear me now?
Yes, yes, we can hear you.
Okay.
You can go on, please.
All right, all right. So you can also see my presentation.
It is now on the screen.
Oh, very good, very good. So first of all, thank you very much for this very kind invitation. I would have loved to be in Cairo, but as you know, due to the pandemic, everything is so difficult right now. But I'm happy to talk and discuss with you the issue of emergency endovascular aortic repair for ruptured AAA. I do not have any disclosures with respect to this talk. So what is the rationale or the background why emergency endovascular aortic repair for ruptured AAA might be the way to go? So first of all, we all know an aortic rupture is a life-threatening complication with very high rates of lethality. So aim number one is to survive for the patients. That's the most important thing in the very early phase of the treatment of this disease. We also know, and we've just heard that, an example of that, that EVAR is safer than open aortic repair in elective AAA due to many things and organ complications, and also safer in terms of perioperative mortality. So the question is whether emergency EVAR is also safer than open aortic repair for ruptured AAA. This was an 82-year-old woman. She presented hemodynamically unstable with a free rupture of a previously unknown AAA. And this is a couple of years ago. We treated that by use of an aorto monoiliac stent graft, in addition with an occlusion of the left common iliac artery, and to perfuse also the left leg, we performed in femoral bypass. In addition, we performed abdominal decompression to reduce the pressure from the bladder. So if you look at the literature, and there are lots of studies outside the latest one for 1 year ago, a meta-analysis of outcomes of EVAR as compared to open repair for ruptured AAA. More than 260,000 patients were included in this analysis, including observational trials and randomized data, for example, from the IMPROVE trial from the UK. And if you look at all the data, you see that the perioperative mortality was in the range of 25% after emergency EVAR versus 38% after open aortic repair. And the odds ratio was 0.54, which was significant. They also observed that the perioperative mortality decreased over time, over the years for EVAR and also open aortic repair. And the conclusion was if EVAR can be done safely and anatomically appropriately, it's a better treatment for ruptured AAA. We looked after data from the German Quality Assurance Registry for AAAs, which we performed, we as the German Vascular Society a couple of years ago. And we looked at almost 5,000 ruptured AAA cases treated a couple of years ago, and you see the mortality was less in the same range as the systematic review, 41% for open repair, 23% for emergency EVAR. But also we observed less cardiac complications after EVAR, less pulmonary complication, less bowel ischemia and leg ischemia. So overall, EVAR turned out to be much safer. We, from my department, looked also at the issue whether volume plays a role in outcomes, so volume in elective and volume of ruptured AAA in the single vascular unit. And what we see here, if we perform an analysis based on quartiles, you see the more patients you do overall, the lower the perioperative mortality rate is. On average, 5%, but if you do lots of cases, it goes down to 4% or even lower. And the same is true for ruptured aortic aneurysm. If you see have an aortic workload of at least 30 cases a year, the outcomes are better. And this was also looked at in another way by looking at the odds ratios. So hospitals with more than 31 patients per year, open endo and ruptured and non-ruptured cases, you see that the elective mortality was significantly worse in low volume hospitals, and that was true for elective or intact AAA and ruptured cases. So what do the guidelines say on ruptured AAA? The Society of Vascular Surgery in North America gives a strong recommendation in favor of EVAR if it's anatomically feasible, and then REVAR should be done is recommended over open repair for ruptured AAA. The ESVS from 2019 was cited already with respect to ruptured AAAs. They give us also a strong recommendation, a grade 1 recommendation to treat hemodynamically stable patient and anatomically suitable patient with EVAR. They also give a strong recommendations to do a prompt CT angiography in the emergency room. NICE is, as we heard, a little bit, bit more conservative. They say EVAR provides more benefit than open refer for most people, especially elderly male people and for women. So it's more an issue, I would say, how to perform emergency EVAR rather than to discuss any superiority or inferiority of EVAR as compared to open repair. I show you how we do that. If the patient comes to the emergency room and he receives or she receives immediately CT angiography, where we can see within minutes whether the morphology is suitable for endovascular repair or not. And what we see here that roughly 70% of the patients are suitable for endo repair. We also need close cooperation with the anesthesiologist to introduce permissive hypotension, and we lead the option on table angiography. We start always under local anesthesia to put the sheath in, a very long sheath, and to be able to perform a suprarenal balloon occlusion. And of course, you need to have many different endografts, also parallel grafts are sometimes necessary, palmar stents or staples for active fixation. And what we always do is that we perform a control CT angiography directly after emergency EVAR. And this enables us to keep the in-hospital mortality in the range of 20% or lower. So emergency EVAR, in conclusion, should be considered as the new standard of care for ruptured AAA. Current guidelines clearly recommend emergency EVAR over open aortic repair in anatomically suitable patients. Emergency EVAR has a significantly lower mortality and morbidity. And of course, in institutions or hospitals where ruptured AAAs are treated, EVAR and open repair should be available and possible. So this is my last case, 77 years old male with a contained rupture of a 70 millimeter AAA. You see here, this was the emergency procedure. The stent graft is already put in, but there was a type 1 endoleak. We again dilated the proximal body and also fixated this by use of aptus endostaples, and then the aneurysm was sealed, and after 12 months it has shrinked already down to 60 millimeters. So that's my discussion point for emergency EVAR for ruptured AAA. I would love to see you again at the latest at the end of the year in Munich to the Munich Vascular Conference. Thank you very much again for inviting me.
Thank you, Dr.